Rini.
Thank you very much. I would like to thank the organizing committee on behalf of the whole
Open.
On behalf of the Hippokration Hospital, we are going to present two cases which were done recently under the leadership of Professor Choufis. The first case is an 81-year-old female patient with worsening dyspnea and orthopnea, NIHA class 3. She was transferred to our hospital due to hemodynamic instability, and she was in constant need of inotropes. Her background consisted of an aortic valve replacement. She had an Epic Supra 19mm valve, 2011. She had a permanent pacemaker implanted, hypertensive, and dyslipidemic. She was on optimal medical therapy, and under quite a few doses of diuretics. This is her ECG. Her pacemaker was working fine. As we can see from the echocardiogram, there is quite a moderate plus mitral regurgitation, and also the aortic valve, which was implanted. We can see here that it was quite stenotic with a mean gradient of 23 and a max velocity of 3.5 approximately. So, 14 years after the replacement of her aortic valve, the lady is having a dysfunction of the valve. As we can see here, after surgically implanted valves, the expectancy of the durability of the valve is approximately 10 to 15 years, very good one, but then we expect to have some problems with the valves. The same thing happens with the cases where a TAV is the first valve implanted. As we can see here, the durability and the all-cause mortality is almost the same in these patients. And as the population is growing older and older, more and more people are having a bioprosthetic valve instead of a mechanical one. When do surgical valves present for valve-in-valve? I mean, life expectancy of 10 years for most of the valves, except for when there are other predictors of early tissue valve failure, such as young age, renal failure, or the valve type is not the best for the specific patient. So we had a heart team convened, cardiac surgeons we have in our hospital, we're lucky about that, also intervention cardiologists, anesthesiologists, and imaging specialists, and we decided for an interventional approach as the Euro score of the patient was 15.5 and STS score 14.1. The guidelines agree with our choice as well because the patient was in high operative risk, to be precise. We had a pre-interventional CT. This is the coronary angiography of the patient a few days before the decision was made. And the two axes that we used was the right radial one and also the right femoral artery, as we can see. From the aortography, we can see that the valve was having quite regurgitation. And as far as our decision is concerned, here we can see all our options for the valve that she already had, and it had an Epic Supra 19. And we need to point out the fact that it is a fracturable valve that has a tissue annulus diameter of 19 millimeters, because it's quite important to know. So it's a porcine valve. And now we can see the procedures. We advance the new valve. And because there was aortic regurgitation, we decided for a balloon, an 18 balloon, to be inflated, as we can see here. And this is the final aortography. We were quite pleased with our result. Manta 14 French used in order to close the right femoral artery. And her follow-up echo, her ejection fraction was slightly under normal, 54%. The mitral regurgitation was now moderate. It was better as expected after the procedure. And also her PASP was under 40 millimeters of mercury. we see that there is a small paravalvular leak, and the max velocity of the aortic valve now it's 2.5 meters per second.
Nice presentation. Very few short comments from my side. First of all, this was, we have to decide very under the pressure of the fact that the patient was admitted to the ICU with orthopnea, and despite the optimal pharmacotherapy, the patient is not continue to be unstable. So we had something to do in an urgent fashion. The second point is that the previous surgically implanted valve was 14 years ago. I would say enough time, because unfortunately we have seen cases after 2-3 years, or in some cases I remember 1 month ago, one case after, let's say, 6 months post-surgical implantation of the aortic valve. So this was good in terms of time. The third point is that, as Irini mentioned, after the successful TAVI, the degree of mitral regurgitation was reduced. Now the patient is have a follow-up for more than 6-8 months, if I remember well, and the patient is doing well, and no symptoms either related with the aortic valve or with the mitral valve regurgitation. That means that TAVI in an urgent situation due to the dysfunctional surgical aortic valve is a nice option, and the patient 1 day after, 3 days after the procedure, discharged from the hospital, and no new admission to the hospital in the last 8-10 minutes.
Is there any comment about this case? I can say that in this case, the heart team is working well. With
I completely agree.
There's no disagree. Yes,
Dr. Padagos.
Congratulations for this beautiful case. And again, the heart team. The heart team requires a lot of things, and especially for the younger generation, requires people to get together. In order to get together, they have to have a common goal, a common practice, a common construction, and less hypertrophy of the ego. Because sometimes it's nice in the conferences to talk about our team, but sometimes our ego is against what's going to be the best of the patient. I can tell you one thing, just for your age only. A year ago, a patient was referred to me, and then it was so difficult that I had to do the heart team. The heart team decided against operating the patient and doing a TAVI. Do you know what the other referring physician told to me? Do you know what did you do? You just tried to prove that I'm wrong because I suggested surgery and you said something different. So, to conclude, in order this to function well, we have all to put our egos down and see what's the best for the patient. Thank you.
But nowadays, the heart team in the United States and European guidelines, they has received class 1 recommendation in all cardiology clinics. But I don't know what is happening in our country, about how it's working. Do you have any idea, any experience?
No, I don't have any idea, but in these lines, I think that it's a good, let's say, practice from our side, starting this registry valve in valve, because for first time we will now have, or we will have data in the next few years about how many patients with dysfunctional surgical valves or with dysfunctional TAVI after a number of years will need a second procedure, surgical or interventional. I would like to ask Kyriakos, who also participate in this case, if you, Kyriakos, want to have a comment.
Good function of the heart team. In Hippokration, we have this a tendency to communicate. And I think the fact is that we have more and more people who are also in the list for TAVI, and they come to our department with, cardiogenic shock. They are in very bad shape. So what do you provide to them? Just a bath? Or you can also do the valve. And actually, in our group, we performed a meta-analysis, and we've seen that it is feasible to perform urgent TAVI, and we see they have 50% reduction of mortality when you do TAVI compared to valve. I mean, the registries that are already, we have the data. So this is also, I think, a point of discussion for the ones who take the decisions, if we can really do urgent TAVI in certain cases. Because a lot of people do not get the treatment. Also, in this case, we had the ability to do the valve-in-valve. We have also the person with native valves. I don't know, Dr. Spargas, if you have any comment on that.
Yeah, I think there was one presentation, I don't remember if it was this morning or yesterday, with all the data showing that BAV nowadays is only when you don't have the device, the TAVI device, or you don't have the TAVI team. So if you're in a hospital that is performing TAVI, you shouldn't do BAV today. You should go directly for TAVI if you decide to intervene. And
but of course, sorry to interrupt you, there are logistical issues in order to go to implant a valve. There is an extra cost. Let's say you don't have sometimes approval from the committee, as you know,
yes,
particularly in urgent case.
But BAV doesn't have an effect. It has an effect of 1 or 2 months, and then you get the same risk. It has the same risk with TAVI. So you get a risk for nothing. So if you have the team, and if you are performing TAVI, you must go all the way to do TAVI. And my comment for this case is that something we all know nowadays, that bioprosthetic valves, if they start to degenerate, they can degenerate very, very quickly, within a day or 2. So these are the cases that even without symptoms, when you see a degenerated bioprosthetic valve, it's an urgent case by default. You should do it as soon as possible.
I think this is the main message, because I remember some case in the previous years when we, let's say, select wait and see strategy, it was a disaster. The patient died. So this is now our strategy. If we see such a patient, we have to do directly go for TAVI.
Sorry for, I don't mean to prolong that, but since we have your experience here, we operate people and we do believe that we're doing better. 10 years ago, we had some firms, some valves, that they're disasters and deteriorated so rapidly that in 2-3 years we have problems. And half of the TAVI cases are around those valves. Today, we do believe that we have valves that we expect 10 to 15 years life survival. So now you're telling us that, because we don't see our patients that often, that you can see patients for having the valve deteriorated in 2 years, and now you just mentioned 6 months. Did you prove anything what went wrong so a tissue valve to the surgical valve to deteriorate in 6 months? Did you find something?
I think this is multifactorial, but of course, I think that it is important the operator, the surgery or interventional cardiology, to do his best at any time. This is, I think, the major issue. In the majority of cases, I think that something went wrong with the selection of the valve. I mean, in terms of the size of the valve. For me, for us, we cannot do TAVI without a CT scan. How many of you, of the surgery, asked for a CT before, let's say, doing a replacement of the aortic valve? I don't think that so many. I am quite sure if you have in your hands, apart from your great experience, the echo, blah, blah, modalities, CT, in order to select the appropriate size of the valve, I am sure that we will have less dysfunctional aortic valves, or at least they will last a longer period of time.
Oh, now we move to the next case.
Yes. The second patient is a 54-year-old man with resistant edema, multiple hospitalization due to recurrent heart failure, and he is in NIHA class 3. He has exertion-related syncope and spasms, despite the fact that he had a pacemaker implanted 2 years ago, actually. His background included a mitral valve replacement in 1999 with a mean gradient now at about 7 millimeters mercury. He has RV dysfunction and cardiac cirrhosis, and this is the reason why he had the tricuspid valve replacement with bioprosthetic Carpentier-Edwards 33 millimeters and right atrium reconstruction on 2013. The pacemaker was implanted to the left ventricle 2 years ago, and his comorbidities included atrial fibrillation, treated hepatitis B, mild pulmonary hypertension, and he had banded esophageal varices that he didn't have any bleeding episodes since 8 years. His medication included all this medicine. This is his ECG. He didn't have orthostatic hypotension. Here we can see we implanted actually a pacemaker to the coronary sinus. And a few months ago, he had a coronary angiography. As we can see here, there's no problem with the coronary arteries. And here are the transthoracic echo images, ejection fraction 45 to 50%, and there is a mild PVL and intravalvular leak in his mechanical mitral valve with a mean gradient of 8, and a mild aortic regurgitation as well. We can see that the inferior vena cava is dilated, and also that the tricuspid valve is stenotic with a mean gradient about 9 millimeters mercury. As far as the dysfunction of a valve, such as the one the patient have, we can see that most of the times it's stenosis the main reason for dysfunction, as well as regurgitation. And sometimes the patient has both mixed valvulopathy, and the need for reintervention after valve replacement, the tricuspid valve replacement, is 0.2 after 5 years. And we see that death has, there are not too many patients who died after the procedure. Now we have a heart team again. I should mention that the patient was assessed by an hepatologist and his stable liver disease, and we also had already done a CT in order to make sure that the angle between the inferior and superior vena cava and the tricuspid valve annulus was okay for us in case of intervention, and also in order to make sure that the right coronary artery would not, and the coronary sinus would not be impinged in case we intervened. So, as it would be the third time that he would have an operation to his heart, we decided an interventional approach. As we already had some experience with MyValve, we decided to implant a MyValve 29 millimeters. His Carpentier-Edwards 33 millimeters Magna had a true ID of 28.5 millimeters, and it's important to know that it's a fracturable valve. So, as far as the procedure is concerned, we used the right femoral vein axis.
Large was the right atrium.
An Ambulance left catheter and room wire to cross through the bioprosthetic dysfunction, bioprosthetic valve, and then advance a J wire to the left pulmonary artery. As Professor said, it's a huge right atrium. Then we exchange the catheter to a multi-purpose catheter, and we advance the catheter to the pulmonary artery. After that, exchange to an extra stiff, actually Landerquist guide wire. And then we can see how slow the inflation is, and that the balloon is attached to the previous valve, and as it's inflated, it becomes even more vertical, and it takes its right position in order to make the procedure actually a success. We used a MyValve 29 millimeters balloon expandable valve using a 14-thread Python sheath and a navigator delivery system, and under rapid pacing, actually, the patient was. We didn't need a TOE during the procedure. So this is the hemodynamic result. And as far as the echo is concerned, we can see that the ejection fraction is quite the same, and the mean gradient of the tricuspid valve is now 3 millimeters mercury. It used to be 9, to be precise. So, in conclusion, we would like to point out the fact that the number of patients needing valve-in-valve implantations are going to be more and more in the future because of the life expectancy, and the patient selection is always of very great importance, and proper multimodality imaging is necessary in order to make sure that we use the right tools, actually, and the right device we select for each individual patient. Thank you very much for your attention.
For the heart team,
thank you very much.
It was not, let's say, difficult what to decide. The patient has undergone 1 time for the mitral valve, twice for the tricuspid valve, so now there is no other choice apart from, let's say, doing valve-in-valve. We are happy the patient is completely now asymptomatic, and he has discharged, because this was the case last Wednesday. The patient on Friday, 2 days after that, was discharged in very nice condition.
So we have no time to thank you very much. Excellent presentation. We have to move to Professor, to Dr. Niños.